one question for you, Larry, is have you found intraoperatively that you perform additional osteotomies correction based on the pre-configured rod? That is, maybe you thought in the past you hadn't done enough and the rod's showing you that you needed to do more.
Yeah, great question, Chris. Honestly, I don't think I have, because in cases I need a lot of correction, I'm still using my standard technique of correcting rods, getting to where I want to get, and then laying, the prevent rod in. So honestly, maybe I've pushed the correction a little bit more, but I don't think I've changed and done a VCR when I didn't plan to do a VCR, or done a PSO when I didn't plan to do it. To tell you the truth, but the amount of force I'll put on the screws, the amount of cantilever I'll do may be a little different based on because what I do is I take a look at the prevent rod before I do my correction to kind of see and put that against the spine. So I'm doing open cases, so I get that luxury, and it gives me a feel for how much I have to do, Chris. So that's maybe one thing that helps me decide before I do my correction maneuvers exactly how much correction I need to match the sagittal alignment of the prevent rod. So that's an advantage, intraop, in other words, if that makes sense.
Yeah, I think you'll remember in one of my talks, Larry, I have a picture of enabling technology, and I have you there and saying, the real win in enabling tech is if Dr. Lanke adopts the enabling tech. It's like making the skilled fighter pilot better. And this gets me to this reminded me from one of the questions in the chat. What made you, as a master rod bender, what made you want to adopt UNIT? Because obviously there has to be something there, right, if you're adopting it. Yeah.
Honestly, it was the first thing was the pre-op planning. I'm going to be able to see the pre-op plan, in 15 seconds. It doesn't take long. And realize, that's the sagittal alignment I want in my patient. Again, as I mentioned, I'm a very visual person. So honestly, it was a pre-op planning aspect of it that really got me hooked. And then, all of a sudden I got this rod delivered that, basically was contoured specifically to the plan I wanted. And I love bending rods, and I still do the rod bending, but obviously we know that also isn't ideal because that weakens the rod, as we all know, right? So the more you bend the rod, the more you notch it. So I think, we still, even with 4 rods, we're still seeing some rod failures, Chris, in our long constructs, right, to the sacrum and pelvis. So I think anything we do to improve, I'm all about improvement. So, this technology is going to let me get better. So that's probably the main reason why I'm using it, honestly. I think it's making me a better surgeon planning my cases and executing my cases right now. And
as busy as you are I'm sure your clinics are crazy, your OR schedule is crazy. One of the questions was, how do you, as an extremely busy surgeon, and I know I see you everywhere, always traveling too, how do you how much time does this take you to add UNIT into your practice and to incorporate it? And
well, I must admit, I'm waiting for my text. I have people, I don't know who they are. They text me when I need to look online on my site to be able to confirm my cases for the next week or two, because I get behind. So it does take some time. It is new for me. But honestly, from the time I log on to the platform, to the time I look at the plan and confirm my plan, if everything is templated the way I like it, it's maybe a minute. And I can tell you that I've been using this almost a year now, Chris. In the last probably 3 months, I think I edit 10% of the cases now. That's my point about the adaptive, iterative cycle of this, that it knows how I do things. And so in the beginning, I had to edit almost every plan. Now I'm editing, I don't know, man, maybe I'll ask you the same question, Chris. How often do you edit your plans? I'm hardly editing my plans anymore.
It's absolutely almost never. And my experience was exactly yours, where initially, the more you have to spend some time with the engineers, right, the human intelligence that's looking at this. Human intelligence is using the machine learning intelligence to tell it what the reciprocal changes are going to be. But you as a surgeon, the first few months, you have to allocate some time to work with the human intelligence at UNIT. But if you do that and you help them to learn your strategy, then 4 to 6 months down the line, you're almost not touching the plans. They're almost absolutely perfect because they learn they learn your strategy. That was exactly my experience. I would say for new unit users, it's really important to allocate some additional time. It's like when you adopt any new enabling tech, you're going to have to spend a little bit more time with it, but in the future, it's going to save you time down the line. And
right. And not only save you time, Chris, but again, it's going to make you a better surgeon, right? You pointed that as well. I mean, I'm so excited about that. I really am.
To that point, Larry, and I think, one of the questions that we get, especially from our European colleagues that don't have as much experience with unit maybe as we do in the US, at least outside of France, is how do you deal with the coronal alignment? I touched on that a little bit, that unit is still really a sagittal planning platform. And I know your practice is, it's a very rare day for you where you only have a deformity in one plane.
That's actually true. Right. I showed the thoracic hyperkyphosis. I saw a lady with a compression fracture. That actually is very unusual for me. So honestly, I had the engineers come see me do a couple of large thoracolumbar cases similar to what I showed Chris, because one of the things they were doing, my rod was ending up too short, because we're lengthening these people by several centimeters, so 4, 5, 6, 7, 8 centimeters, and some of these people with very large curves. So their rods are ending up too short. So they realized they have to add rods whenever we correct a coronal plane malalignment, and we're producing a fair amount of coronal straightening and correction. So again, it is tricky. We don't have that down yet. But again, I'm learning how to use the sagittally contoured straight rods to correct my coronal plane deformities, where I've never done that before. And it is a process, but I'm getting better at it. And the thing I like about it, as I mentioned, that rod is stiffer, right? It gives way less. And I like that, because I don't like rods to give in, right? Especially if it's set in a sagittal plane, right? I want it to stay there. Obviously, in the coronal plane, it's going to give in a bit. But I think, we're used to kind of working the spine and performing our corrective maneuvers more with these patient-specific rods than straight rods, to which I still obviously resort to in the most severe cases, but less and less over time, Chris. So that's also exciting. It's, again, it's a process, right? It's a learning process I'm going through right now, but I don't mind it, because it's ultimately making me a better surgeon. And honestly, I'm not spending more time in the OR. If anything, I'm spending probably less time, honestly, to tell you the truth.
Yeah, and one additional point, occurs to me, where if they're master surgeons like you entering their data into UNIT, hopefully in the future, other surgeons will be able to benefit from that information that would be there about how.
You made a great point, Chris. I mean, not everyone can be part of a major study group, but if you can enter your data in this platform, and it's obviously going to be much more than radiographic data, as you mentioned. And again, you're the cusp of leadership on this, but that's going to be so powerful, right? For everyone being a better surgeon and treating patients better. And we need that, as you know. Our profession is unsustainable unless we get to that point, right? These are just way too expensive, primary and especially revision cases, as you highlighted. So we have to get better at this. And it just you and I can't be the only two getting better at this, Chris. Everyone has to get better, right? That's the key. And so you hit the nail on the head with the way that we have to approach this. And everyone doing this kind of surgery has to commit to this, right? Because we have to all get better.
Absolutely. And while we're on the subject of expense, let me ask you a quick expense question that came up in the chat, which is, do you use UNIT for your accessory rods as well, or are those off-the-shelf rods?
Yeah, so I have 2 rods per case created. And if I'm using a correcting rod, a straight, Slayer correcting rod is the correcting rod, then I'll usually drop one of the other rods in, top to bottom as my confirmatory rod. Then I'll use the second rod as one of my short rods in the lumbosacral region, where obviously I want the benefit of a non-notched rod, right? We know that you're going to have a stronger fatigue life on that rod. So I make sure I use that as one of my 3rd or 4th rods, depending on, how my alignment is. So I'm always using the 2 rods. So, and very rarely I'll use correcting rods for both sides, but I'll have my holding rods then be the 2 pre-bent rods that I'll just cut short. If I'm doing, like a T11, the ilium 3rd rod or 4th rod, I'll use that. So I'm always using those 2 rods, and more, my point is I'm using them actually as a primary correcting rod and for sure as a holding rod for the whole spine for total spine construct T2 to sacrum.
There was one technical point that came up in the chat, Larry, that reminded me of something we do. We go up to C7 when we do severe Camp-McCormick patients or sarcopenic patients, Parkinson's patients, and you had gone up to C7 in your severe, I think it was C7 in the severe kyphosis case.
Right, I did, yeah, you're right.
Do you, when do you choose C7 versus, T2 and...
yeah, mainly it's a sagittal plane issue. Also, I look at now with the X-rays with the MRI and CT scan. In patients with very severe kyphosis of soft bone, my PJK rate is less if I include all the kyphotic disc and even the top neutral disc, right? I mean, if we treat a Sherman's kyphosis, the analogy is if we treat a Sherman's, we never would just treat the kyphotic segments distally. We always grab the first lordotic segment. And that's why, and then we don't get DJK. So the reason we get PJK is we don't grab the first lordotic segment because often that's in the cervical spine, right? So in a revision case or in a very severe challenging case, I'll usually want to grab ideally the first lordotic segment or certainly include even the neutral segments above. In a healthy person with good bone, I don't think you need to do that, for a primary adult idiopathic, but in a 70-year-old with a 110-degree kyphotic osteoporotic collapse with a T-score minus 4.2, that's why I did it. I went all the way to C7 to grab the first lordotic disc above at C7, T1.
Yeah, and with navigation, you can often place screws that are compatible with a 5.5 or 6.0 system. So you can just run the rod all the way down or even with a laminotomy. I'll clean up two questions addressed to me. Are changes in HRQL scores for reoperations and other specialties similar? The answer, that's a great question. I don't know. I'd love to have that information and put it in a future version of the talk. I'm not sure whether that's something that's specific to musculoskeletal or spinal deformity interventions. Great question on the lumbar-only tethers. We did not see an impact of lumbar-only tethers. So they didn't seem to work when we terminated in the lumbar spine. So we don't use them for our short segment constructs, only our T10s or T4s. This is a great question for you, Larry, about your preoperative workup. So what are you using right now to do your unit plan? In the early days when you were having those conversations with your unit engineer, were you talking about your supine plane X-ray, your standing X-ray and the mobility of the segments? Were you using any CT information, obviously, whether something's fused or not? How were you, what were you using to make your decisions?
Yeah, all that. I'm a big fan, as you know, comparing the upright to supine images. That gives me, again, an indication how much carpentry I need to do to the spine, Chris. So I still use that, and I've talked to them about that. I think that's very important. Also, I think that's the kind of information we're going to need. There's a further question down the line. How do we predict the unbending of the rod, like when you're trying to produce the kyphosis? I think that we have to have some comparison of what the spine looks like upright and recumbent, whether it's CT data, MRI data, or supine images. We have to have that factored in. And that's going to give us our delta in postural correction that will help us predict exactly, along with our osteotomies or whatever carpentry we're doing intra, to predict how much the rod's going to unbend, because we still don't have it figured out. But guess what? We will ultimately, because it's just data, right? It's just new data that has to be applied that we can often figure out. Then, again, if I want to have 35 degrees of TK and I start out with 17 and, basically in this kind of patient, whatever my CT MRI image looks like when they're laying down, that I'm going to predict I'm going to have to have the rod start at 45 degrees, then up at 35 degrees. So up to now, even 30 years into this, it's a complete guess to me. How much kyphosis I put in a rod in the thoracic region in the scoliosis correction to produce the amount of kyphosis I want. I'm totally guessing. We need to get rid of that. If I'm guessing, everyone's guessing, right? We need to get there. We need to operationalize this to have less variability, which, as you know, in any area of medicine produces better outcomes when you have less variability.
And to that point, there are two really great questions in the midsection of the chat. One is about your prior experience and does that inform your unit plans? And one thing that we've noticed is we're all subject to a bit to self-serving bias, which is our losses, our complications were bad luck, and our wins were due to our skill. And one thing that we see through unit and actually having third parties like the engineers look at our cases is you say, oh, I can get all that correction with a type 2 osteotomy and a TLIF, and they say, actually, you haven't been getting that correction. Right. You need to rethink that. So that's one area where I've seen a real impact is when they say, actually, your combination TLIFs type 2s don't give you that angle that you maybe you wanted. And the final one, which is just so great, maybe we can, I see the end coming, but I can't go without addressing this one question, which is, do you see payers eventually requiring case simulations and whether they're going to be successful or failure, really maybe in every aspect, mechanical failure, clinical failure, et cetera? Absolutely. We're all going to be building digital twins in the cloud ecosystem environment and then trying to figure out what's going to work for our patients. But I think hopefully it'll be us doing that as surgeons who care about the patient more than insurance companies coming in and requiring that.
Yeah, we definitely need to be at the table on that one and in charge of that, Chris. So that's absolutely going to happen, not only with patient selection, but the optimal techniques and then intraop execution. It's all going to have to be optimized and quantified, right? I mean, there's just too much at stake here, right? To have a Wild West approach. I mean, honestly, I loved it. I grew up with that. We kind of have the artistry of being a spinal deformity specialist. Those days are going to be gone pretty soon, I think. But it's going to be better because at the end of the day, the vast majority of spinal deformity patients are going to be treated better, more consistently, for better outcomes. And I'm all for that, right? That's the mission of the Scoliosis Research Society. And that's the mission of anyone who's dedicated their career to these kind of surgeries in these patients. So it's a very exciting future.
Blair, you want to take us home? I think that was a perfect ending statement by Larry.
Perfect. Thank you so much, Dr. Linke and Dr. Ames. So that's all we have time for tonight. If you're looking for additional educational resources, please scan this QR code on the screen to see more program offerings for Unit ASI, including faculty consults, Unit showcase centers, hub demo reviews, and then Spine Academy. Thank you all so much for joining us this evening. A sincere thank you to Dr. Ames and Dr. Linke for your expertise and discussion. We really appreciate your time. Have a great night, and we look forward to having you join us for one of our future medical education programs.
Right. Thanks, Blair. Thanks. Good to see you, Chris. Be good, everyone.
Have a good night, everyone. Thank you.
Bye-bye.